talk about coalitions in adults, and actually a little bit about coalitions in children as well, because it's hard to talk about coalitions in adults without talking about coalitions in kids. I'm actually at Brigham and Women's Hospital now, and I have no relevant disclosures for this talk. So first, some brief background. Most coalitions are a developmental failure of differentiation and have been shown to have a component of autosomal dominant inheritance. They can be fibrous, a synchondrosis, or bony, or a mixture. Calcaneonavicular and subtalar are the most common. Only about 25% of those two are osseous versus the rest, which is, complex coalitions, combinations, things like these tarsometatarsal coalitions. The rest are more like 3/4 osseous. And about 50% or more are bilateral. So before we get into the discussion, a few points. Just like my children couldn't be any more different, each coalition is very different. This is for many reasons. It's the size, the location, the deformity that's associated with it, the stiffness, the type. The literature often combines a lot of these together, which makes it really hard to interpret. And there's almost no literature in adults on these. So I could just end my talk now and say we don't know, but we're going to go through the literature. So in order to discuss the coalitions in adults, you really need to discuss treatment in children, partly because that's when they originate, and partly because we don't really have data in adults and we need something to base our treatment algorithm on. Also, children are reaching skeletal maturity when these are resected, so maybe they're not so different. There's thought, like any contracture, that as time goes on, they become stiffer. The pliability of the soft tissues may be greater in children, and that may be why adult treatment is a bit different. But in children, they're treated generally with immobilization. About 30% resolve completely with immobilization. And then excision, with some deformity correction or fusion occasionally, but much less in children. There are some assumptions and some dogma associated with treating these in children, that subtalar do worse, that you always need to interpose, that if it's greater than 50% of the subtalar joint that you need to that you need to fuse, that resection won't be successful, that you always need to correct the deformity, and that you shouldn't resect if there's some degenerative change. That dogma is being called into question with some newer pediatric studies. As adult surgeons, we're conditioned to always treat the deformity, and that's not necessarily true with kids, at least in the short term. Now, as time goes on, that deformity may lead to other problems, but at least for the initial surgery in children, that might not need to happen. So a recent prospective study of 55 patients at 2 years, which short, but even when resecting greater than 50%, and even with a large valgus deformity, without correcting it, there was actually no difference in functional outcomes at 2 years. Posterior medial coalitions at the subtalar joint may do better than medial facet. And even after resecting these, there's a nice study from 2008 looking at hindfoot kinematics. And even after resection, even after freeing it up and feeling like everything's great and free in the operating room, the kinematics aren't really restored. Now, so what happens when these post-op kids get to adulthood? So that's one sort of concept we need to look at. There are a few long-term studies. We're talking, patients in their 40s, 50s, and above. Most of these studies are sort of shorter outcomes, and if they're resected in kids, that means we're looking at them in their 20s. The first study is a 14-year follow-up, and they only did 2 deformity corrections, and even in over 50% of the subtalar joint involved in higher degrees of hindfoot valgus, these patients still were doing quite well at 14 years. The second study I thought was interesting because all of those patients at minimum 5-year follow-up had some degeneration on x-ray, but it wasn't clinically significant. So maybe if people have arthritis, or even a little bit of arthritis, maybe we don't have to automatically go to fusing them. And then the final study said that there was about a 15% reoperation rate, and that those with fusions were more likely to require another fusion. Now, whether that's because the deformity was more, was stiffer, or a bigger deformity to cause the fusion in the first place, that is not known. But anecdotally, I mean, I would say pretty well. It's not like you're seeing tons of patients come into your clinic who had, a resection as a kid and are now doing awful, at least not in my practice. So as adults, this is more likely what comes into my practice. So I just recently saw these few patients. This patient, 46-year-old male, stiff hind foot, new onset sinus tarsi pain after a sprain, and he actually had a coalition resected on his left side as a kid, and he's now in his 40s. That side's fine, and you can see there's maybe some extension of the calcaneus there. It's hard to see, but maybe that's a little bit elongated. Second patient, 36-year-old guy with medial-based ankle pain. He'd been having pain for a little while, just started getting worse, and you can see the C sign on there, no instability. And then this third patient here, this is a gentleman who had a known coalition that was treated non-operatively as a kid, and now he's coming in just with some soft tissue pain, basically medial pain, lateral pain, pain in the Achilles, in the arch, but he's able to run for exercise. He's 22, so he wants to have no pain. So that's more what we see in our practice. So what do we do with these patients? In adults, they more often present incidentally, sometimes after an injury, something like an ankle sprain, less likely to present with spasm, but a lot of them do have some soft tissue contracture and pain just from being flat for so long. The pain may be from the coalition, but the pain may also be from something else. It may be from impingement from a flat foot. It may be from associated arthritis. It may be from stiffness or contracture. So in these patients, I think the most important thing really is to determine the etiology of their pain. What is it? Is it the coalition or is it something else? I typically, in addition to radiographs, will get a CT and oftentimes an MRI with these patients, not always, but MRI when looking for, more soft tissue pathology or to see if there's any type of edema at the coalition itself. Selective injections can be helpful as well if you're not sure of the source of pain. So back to my patients, the first one with the calcaneonavicular coalition, I got a CT. There wasn't any bony bridging there. But from the time I got the CT, started him in therapy, actually started feeling a little bit better on that side, so we decided to hold off on anything further at that point. Second patient, big coalition, bony coalition. You can see there is some edema sort of associated with the coalition itself, but pretty good size. And in general, the joint's looking pretty good. He had a CT as well. And then the final patient, he actually had some remodeling changes of the subtalar joint. You can see sort of through there. He actually remodeled through the joint a bit as well. So in terms of non-operative approach, adults, potentially it's more successful because they've been living up until this point with no pain. So it's, there's one study that showed even up to 67% success with non-operative treatment as compared to kids, which is closer to 30. With these patients, PT is really important because there's a lot of contracture involved, stiffness involved, especially if they hadn't been painful prior. And of course, bracing inserts to support any type of deformity and potentially injection. So in terms of surgical considerations, again, we don't know, there's not great data, but it's important to find out what's causing the pain. Is it the coalition itself? Is it degenerative change, impingement? Is the deformity flexible or is it rigid? And what are the characteristics of the coalition itself that you can find out on CT, weight-bearing CT if you have it, and MRI? In terms of option, you have resection of the coalition, fusion with or without resection of the coalition, and then associated deformity correction. We do not have much data in adults in these conditions, but this one study looking at endoscopic resection showed pretty darn good results short term. And they found that people with a posterior coalition tended to do better than more anterior, which has been shown in other studies, and that fibrous coalitions did better with this approach as well. And then this study, which has not yet been published, but was at the AOFAS at home, so whoever published this, because there's really not much else out there. But they did an adult resection of coalitions looking at 65 patients and actually found that there was a higher reoperation rate than seen in other studies and seen in kids. About half of those were fusions, so 11 patients were fusions, and some of them were exostectomies, but they did quite well with just resection. In terms of technique tips for resection, make sure you take enough bone. You want it to be fully mobile. In the NC joint, you want to get the medial plantar aspect. You can use an elevator through the sinus tarsi going out medial to try to find that coalition, because these can be really, really hard to find. And there's a nice study that looked at 3D printed guide actually to model it, to try and help you figure out exactly where to put your osteotome and how to resect it and make sure that you are in the right place, because it can be really hard when you're looking at that medially to figure out where to go. So for the other patient who was not treated non-operatively, I opted for excision. And then lastly, in terms of fusion, some questions that we don't know the answer to yet are, do you resect the coalition when you fuse it or do you not? And I think some of that depends on I did an informal poll of a lot of my partners and friends, and everyone basically said the same thing. Well, it depends. It depends on how big the deformity is. It depends on the size. It depends on whether it's bony or fibrous. But I think if you can get a good correction with resecting it, and it's easy, you can do it, I think it makes correcting the deformity easier if you can move it. And then there's really, again, limited data behind this. This is one small study looking at arthroscopic fusion of subtalar coalition. And they did not take the coalition down, and 6 to 8 excellent results, all the patients fused by 12 weeks. So now we're going to move on lastly to my opinion, which I always joke is like the level 8 evidence, Liz's opinion, the Ocho. But here's my algorithm. So most importantly, determine the source of pain. Advanced imaging if you need it. I have a low threshold to resect because you're not really burning bridges by doing that, and it's a bit faster of a recovery. So I have a really low threshold to try to resect it, have a good conversation with my patients about it, even if some radiographic arthritis. Correct the deformity if painful. If they're stiff, if they have symptomatic arthritis, really fusion I think is more predictable. And there's lots of tweeners, lots of individual decisions with this. So again, reasonable to attempt resection, no consensus on interposition or when to fuse, and may not need to correct deformity if not painful as shown in the pediatric literature. Thank you.